Good afternoon, everyone, and thank you so much for joining us for another virtual cardiology lunch and learn session. Today our topic is about syncope and chest pain in children, to refer or not to refer. Feel free to raise questions throughout the talk. There is a chat. You can unmute your phone if you prefer and speak into the microphone. But if you're not speaking, please try to mute your phone. The instructions are provided. I have no disclosures. Our goals today is to identify when to refer a patient presenting with syncope to the cardiologist, recognize the potential charge implications of low probability referrals and testing, and finally, share with you some curricula that we have developed teaching residents the communication skills surrounding referral and consultation. Let's start with a case. A 15-year-old young boy complained of syncope during activity. The family history revealed depression, a heart attack at 52 years of age in the maternal grandfather. The examination was normal. Let me open it up and feel free to put in the chat box what questions do you want to know about this patient before you make your decision to refer or not to refer. Feel free to unmute your phone and tell me what things should make you scared or should make want to send this patient to cardiology. So in this particular case, this 15-year-old boy was running the laps, and at lap number 22, as he was going up the mountain, he actually collapsed. He did feel chest pain afterwards. So this is someone that the pediatrician referred to cardiology appropriately and was evaluated. What this patient had is something related to the coronary artery. In the normal child, the right coronary artery originates from the right side of the coronary sinus, whereas the left coronary artery originates from the left-facing coronary sinus. This blood vessel is the pulmonary artery. In some children, the left coronary artery originates all the way from the right, and in others, the right coronary artery originates from the other facing sinus. The problem with those two kids is that this coronary artery, not only is it running between the great blood vessels, but it actually has acute angle. In this particular patient, her right coronary artery was originating all the way from the left side facing sinus. This patient underwent surgical repair and is doing well. The pediatrician of this patient should be congratulated for identifying a potentially life-saving condition that the patient presented with. So when it comes to the heart, what are the causes of cardiac syncope and chest pain? Well, hypertrophic cardiomyopathy is the most common cause of sudden death in an athlete, followed by coronary artery anomaly. I shared with you one of those cases. Aortic valve stenosis, supraortic valve stenosis is another cause of coronary artery ischemia and syncope and chest pain. Pulmonary hypertension, pericarditis, myocarditis, and all rhythm abnormalities. In children, between 5 and 6 years of age, sometimes it's hard for them to differentiate palpitation from chest pain. So when should you refer such patients to us? In the patient complaint, you want to know what the relationship of the chest pain to exercise. Were they actively running, or did they finish the sports and 45 minutes later they started to feel dizzy or fainting? Chest pain that radiates to the back, jaw, left arm, or left shoulder is a concerning chest pain, might indicate ischemia. Again, chest pain that's worse with supine position might suggest pericarditis. If you have a fever, we might be dealing with myocarditis or pericarditis. And in children who faint with no warning, sudden onset ought to be referred to cardiology. In the patient's past medical history, what we want to know is, did they have any underlying heart disease or hypercoagulable state, immobilization, increasing the risk for pulmonary embolism? Family history is absolutely important. We want to know what the family history for any sudden unexplained death. And your job as a pediatrician is more like a CSI detective. You want to know if there is any unexplained drowning, car accidents, did any children die less than 1 year of age, did anybody die for no good reason, cardiomyopathy, pacemaker less than 40, and any hypercoagulable state. All of these will be risk factor and will be significant enough to send such patients to cardiology. On examination, here I'm focused on identifying cardiac disease explaining chest pain. So I will be worried if there is tachypnea, fever, ill appearing, if there is any swellings in the extremities or pain, non-innocent heart murmur, muffled or distant heart sounds, gallop to suggest heart failure, loud second heart sound, friction rub, and peripheral edema. Now, the reality of things is that over the years, we have seen a rise in the number of patients seen in cardiology with chest pain and syncope. This came from Boston Children, and from 1998 to 2011, we saw 4 times the number of patients referred. What we know, the incidence of cardiac condition has not changed in the general population. Now, Dr. Ray Ellen Cavey from Rochester and her fellow looked at patients who presented to cardiology with chief complaint of syncope. And what she found is that 60% of those who had a benign vasovagal syncope did not have any medical red flag criteria for referral. This is why we decided to conduct our first project. This project was published recently, and it's an analysis of the standardized clinical assessment and management plans, along with Pediatric Health Information System and the National Ambulatory Medical Care Survey. The reason why SCAMS was initiated was to reduce practice variation, unnecessary testing, and improve care. In this particular project that I want to share with you, our goals were to determine if clinical indicators, red flags, identified the population of children with chest pain and whom cardiac disease explained their complaints. And second part was to measure the incidence of low probability referral and the charge implications associated with cardiac testing in this patient group. So why do we develop such QI projects? Well, first of all, we know that the practice varies among different cardiologists. So when it comes to ordering echocardiography in patients presenting with chest pain, I'm the first one to admit that Harasha 2008 is absolutely not the same as Harasha 2017. And as you can see, for daughters, less hair, but also the change in behavior. I admit that as one matures, the frequency of testing changes. And, you know, as far as you, the pediatrician, is concerned, the fate of your patient, whether they receive an echocardiogram or not, should not be determined by the age or the experience of the cardiologist. That the patient characteristics themselves should be the determining factor to whether to do an echocardiogram or not. And that was the spirit and the reason why SCAMS was initiated. So in this particular project, we had 3,179 patients who were seen across 13 academic and community centers. What we did is we looked at those patients the way that a pediatrician would look at them. The first thing that you will do is you will get the history of present illness. So anyone with a concerning history of present illness was excluded. We had 1,632 remaining patients. Of those, 24 had a concerning past medical history. And of the remaining patients, 66 had a concerning family history. And finally, 31 patients had a concerning physical examination. This formed the group 1, which represented 52% of the entire cohort across the 13 and academic community centers. 47.7% of the patients were part of a group 2. Those are the children that had absolutely no reason to be seen in cardiology. And when we looked at the incidence of a true cardiac disease, we found 8 patients in the entire cohort to have a true cardiac disease explaining their chest pain. Yet all of them were part of a group 1, the group that had concerning elements. Group 2 had absolutely no concerning elements and had reassuring findings and did not have a cardiac disease explaining chest pain. If one were to apply the red flag criteria that we identified to identify cardiac causes of chest pain, you will be able to do so with 100% sensitivity. Now, as you can see, the specificity and the positive predictive values are lower, and that's because the prevalence or incidence of the disease is very low. In the entire cohort, cardiac disease explained chest pain in 0.25% of cases. Now, as someone who really enjoys giving good news to families and parents, I have to say that nothing brings pleasure to me than a chief complaint of chest pain. I hope now you understand why. Let me stop here for 1 second and open it up for any questions from the audience. Feel free to type in the chat or unmute your phone and ask a question. Okay. So the next phase was to look at the pediatric health information database to identify how often the prices and the charges associated with each testing done. In the benign group, and here I'm looking at the 15-11 children who did not have any reason to be seen in cardiology. The cardiologist ordered an EKG in about 90% of cases. An echocardiogram was ordered in 23% of cases. We did exercise stress tests and multiple rhythm assessments as well as cardiac MRI. The Pediatric Health Information System database is an administrative database across 43 non-for-profit pediatric organizations. It provides you with charge data on different testing that one might do. As you can see, we had the median, first, third quartile, minimal, and maximal charges. And those were the tests that were performed in the benign group. Now, as you can see, charges varies according to different centers. To simplify it, we use the median charges across the centers. Doing so, and across the 4-year period of the scams, $776,000 in charges occurred in the scams group. Now, as you know, charges are not the same as cost, nor do they reflect reimbursement. Now, we took this information and accessed the National Ambulatory Medical Care Survey. In 2012, 625,000 visits occurred at pediatric offices related to chest pain. We know that general pediatricians refer on average 1 out of 40 consecutive visits. This gives us an N of around 1,500 patients. If our data is true, that 47% of patients seen in cardiology did not need to be seen, this suggests an N of 7,415. And if the ordering habits of cardiologists across the nation are similar to those involved in the scams cohort, one would expect $3.8 million in charge saving every year when we stop referring such patients to cardiology and stop ordering such tests. Now, you might say, what's $3.8 million to the national cost of healthcare? Well, imagine expanding the knowledge from this to other cardiac complaints, syncope, heart murmur, etc. Then imagine expanding it to other chief complaints, abdominal pain, headache, ear pain, otitis media, and the referrals to ENT, and then expanding it beyond pediatrics to the adults and to all fields of medicine. But the question is, why such referrals? Why do we have so many referrals out to the subspecialists that, you know, many of us would say that they did not need to be referred? In the scams cohort, we asked the cardiologists, why did they order an echocardiogram when it was not indicated? So 23% of cases, they ordered an echocardiogram when we did not think it was appropriate. And in 14% of them, the answer was parental anxiety and parental demand or preference. Now, remember this figure, because we learned from Johns Hopkins that 1 out of 6 pediatric referrals are made under the influence of parents. You see the similarity here. Part of the reason why we see such referrals is parental anxiety and parental demand. Now, what we know about non-cardiac chest pain is that there is a high frequency of underlying depression in the patients, anxiety, panic disorders, and there is a much higher somatization in parents with non-cardiac chest pain than, for example, innocent heart murmur. Now, this issue with subspecialty referral is not unique to one geography or one area. We know that there is a gap in education in residents when it comes to subspecialty referral. Dr. Eli Hamburger from Children's National and her colleagues found that less than 50% of pediatric residents graduating their training felt comfortable or prepared addressing anxiety as it relates to referral and subspecialty consultations. They also had focus group with primary pediatricians who identified gaps in their education when it comes to red flag criteria for referral, how to counsel and reassure families that do not need a referral when they present with a common complaint, and many pediatricians felt pressured by concerned parents. The American Academy of Pediatrics came up with the referral and consultation as one of its entrustable professional activity that all of our residents graduating from our centers across the state need to be competent by the time that they graduate. So at Children's National, we developed a curriculum to teach residents the communication skills surrounding subspecialty referral during the cardiology rotation. Now, this curriculum focused on two things. Focused on identifying those who need to be seen, and it also focused on what skills as a pediatrician you need to have to make sure that the family follow up with the recommendation for referral and at the same time address the anxiety and the underlying issues with parents who did not feel that a referral is needed. And when you are dealing with complaints like simple fainting, the majority of those patients ought to be managed in the pediatrician's office. Often, it is the parental demand or parental request that forces some pediatrician to send them to the specialist. So we had embedded within the curriculum the skills needed to keep those patients in the general pediatric service. The goals of this particular project was to evaluate the effect of a learner-centered Syncope curriculum on improving resident confidence in making a referral decision for Syncope patients, and to explore if the residents' overall self-efficacy, standardized parent ratings, and medical knowledge improved post-intervention. At the beginning of the rotation, the residents spent time doing a pre-test to have 7 questions on Syncope. They filled out data on their demographics, and they met and counseled 2 OSCE cases, one of them requiring cardiology referral, and the other one is a benign simple fainting that could be managed at the pediatrician's office. And then the standardized patient, those are paid actors from George Washington University who acted like the mothers. They evaluated the residents. Midway through the rotation, we spent 90 minutes with the residents, teaching them the communication skills needed to address these issues, along with an interactive case-based presentation on Syncope, when to refer and when not to refer. And then we spent time practicing with the standardized patients who provided feedback to the residents at that time. At the end of the rotation, the residents filled out again the Syncope knowledge MCQ, along with the standardized patient performing checklist on the residents after they did 2 similar OSCEs, similar themed OSCEs, but not identical. And then we asked the residents to fill out a self-efficacy questionnaire in a retrospective pre-post fashion. We had 48 residents. The number of residents who improved their confidence in triaging to refer or not to refer increased from 28% to 98%. Almost all of the residents had an improvement in their self-efficacy. The mean went from about 70% to 86%. And as you can see, the mean is not very low. Those are second-year pediatric residents that you think would have some knowledge coming to us after they have done medical school and first year of internship. The standardized patient rating also changed from 61 to 76% of cases. Every time I look at this slide, I still don't understand why would there be a couple of residents whose performance dropped. Still don't understand it. But what was more important for me is to see how many of those residents encountered actual patients with syncope during our rotation, and that was 41% of cases. As an educator, this is really important for me because part of the evaluation that we evaluate the residents on is their ability to counsel patients with chest pain and syncope during the cardiology rotation. The reality of things is that we were not providing them with adequate patient load. This is why simulation is very, very important in medical education. But the second question is, what was the impact of seeing a syncope patient or bedside teaching by an attending on their performance? And what we noticed that the improvement that we have seen did not change based on whether you saw a true patient with syncope or not. The success in this program led us to move along and get to a larger program along all subspecialists. The picture here shows Eli Hamburger, who's the principal investigator for the American Board of Pediatrics when it comes to subspecialty referral and consultation. Jeff Stakis is our simulation leader. Mario Cellini is Vice Chair for Education. Karen Lewis from GW, she is the one who trains all of our standardized patients. Many of you know Larry Greenberg, he's my mentor, and Devesh Agarwal is our program director. So we came together to develop a new curriculum focused on the communication skills. This was a 4.5 workshop. The focus of this is literally the communication skills. So we made it into an online blended module. The residents will be taught how to counsel a child with syncope ahead of coming to the presentation. They will get 2 different OSCEs and then an intervention followed by 2 OSCEs, and similar tools will be filled out. Now this curriculum is slightly different than the typical OSCE, and you will see how. So this is a snapshot of the syncope module and then blended learning that the residents will do. An example of a patient who was seen in the past is Mrs. Turner and her son or her daughter Jen. They are established patients in the practice, and she had a heart murmur when she was young. It's about 4 o'clock, the pediatrician's office. The patient fainted 40 minutes after a lacrosse game. There was a reassuring finding, and she had a benign vasovagal syncope. I put this up because I want you to realize how the focus of this is the communication skills. We are providing the residents with all the knowledge that they need to. We're even providing them with what the patient's final diagnosis is. There is no tricks in that. When you, the pediatrician, are encountering the families and getting the history, present illness, and family history, you get the vibe. You get where the family is going with the information. Are they sad? Are they mad? Are they worried? You get all of that. But because we took all of this away from the residents, we provided them with the emotions that the mothers displayed during the encounter. The goal of the presentation now is for the resident to walk in and talk to the family and reassure her. So I will play this clip and have you guys watch it.
After listening to your story, listening to all the information about your family, and doing my exam, I think what's going on with her is this condition that we call vasovagal syncope, and that's kind of a confusing or kind of big scientific word, but basically it just means that people kind of have these fainting spells, and it can be associated with a lot of different things. Commonly we see it associated with heat or having exercised, in the last hour or so without really replenishing their fluid. Sometimes people can get it if they see blood or have other sort of triggering events. But it's something that we commonly see, especially with teenagers, actually. And can it be a lifelong condition? It can be something that people have for a long period of time, although a lot of people will outgrow it. I think the people who tend to have it for a more long period of time are people who have a specific trigger, like seeing blood or things like that. For some of those people, it can persist longer. or with teenagers, sometimes they can grow out of it. And the good news is that it's not dangerous to her overall or lifelong health. And so it's not a dangerous condition. It can be startling, for sure, and it can be something that scares us when we see it happen, but it's not dangerous or threatening to her lifelong or overall health. Okay. And so for that reason, that's something that we feel like we can manage in our office. And there are strategies that we can give her and give you that will help her kind of develop a tolerance to some of these exciting events. What happens inside the body is that you have these blood vessels that dilate, and it basically causes not enough blood to go to the head, so you get dizzy and you pass out. But there are things that we can do to work with Jen to basically get her body more used to those feelings and not have as drastic of a response to it.
So what the residents did is she counseled the mother about the neurocardiogenic syncope. She reiterated that this is a benign finding, that it's most likely related to the vagal tone. Children, after they stand for a long period of time or in hot days, the blood pours down to the lower limb. This will reduce the amount of venous return back to the heart. The heart will try to compensate by squeezing vigorously, which will stimulate certain receptors. These receptors trigger the vagal nerve. It's the same vagal nerve that will be triggered in someone who sees the blood or gets very emotional at church or when they go to the bathroom. It's the same nerve that gets stimulated. This nerve will lead to further bradycardia, and it will also further vasodilate the peripheral muscles, pulling the blood away from the heart. At that point, many of the children will feel dizzy, blurring of vision, some will have nausea, throwing up, and God's way of protecting us is by making us fall down to the floor where gravity no longer becomes a factor and the blood redistributes and we wake up again. The maneuvers that the resident was going to teach the patient when the patient came back were what we call isometric contraction, squeezing of the hands and the legs to try to bring the blood back to the heart. And if that doesn't work, then the child should lay down with nothing under their head and elevate their legs. This is to abort the symptoms. Now, what we also counsel the standardized patients or the families is that it's very important to try to prevent syncope from happening, and that's by increasing the amount of fluid every day that you drink. You want to make sure that the color of the urine is always clear, a daily breakfast, salty snacks. This is the only condition that we cardiologists will advocate for, salty snacks. So that's what the residents did at that point. And again, if anybody has any questions, feel free to ask me now. Either by unmuting your phone or by chatting. Now I know, unfortunately I don't have any questions, so I'm going to go ahead and move on. So I know that it's sometimes difficult to counsel patients when you know what the right thing to do. You know, I know that you guys know the medical knowledge surrounding syncope, how to prevent it, how to abort the complaints, all of this. But what would you do when the mother does this? So let's listen to this video clip now.
Isn't it a good idea just to get checked out by a cardiologist to be on the safe side? I read this article in Parenting Magazine about sudden death in athletes. It sounded really scary. I mean, these are really fit young people who haven't had any history of...
I'm sorry, I'm getting a message that the video is not playing properly, so I will open the video now directly. I hope that this video will work.
isn't it a good idea just to get checked out by a cardiologist just to be on the safe side? I read this article in Parenting Magazine about sudden death in athletes. It sounded really scary. I mean, these are really fit young people who haven't had any history of any kind of heart problems, and then a friend of hers was taken off the field during a game just last month, and I don't know the details, but she's getting a workup now, and it's just, I mean, wouldn't it be a good idea just to be on the safe side?
So the things that we think about with young athletes who have these sudden events in the field are two different categories of problems. One is we worry about a structural problem, specifically it's called hypertrophic cardiomyopathy. And then we also worry about arrhythmias. So the good thing about you bringing her in to see is that we could look at her history and look at her exams to see if she had any signs that she could have those. Because a lot of times, you know, when you dig into those athletes' histories, or if you do a more specific physical exam looking for those problems, then you start to see red flags.
And she didn't have a heart murmur when she was a baby. They said she grew out of it, but maybe there could be some underlying thing.
Yeah, so a lot of kids have heart murmurs when they're young, and they definitely can grow out of them. The heart murmurs that we look for with the diseases that athletes get are very specific heart murmurs. They have a very specific sound pattern, and they have very specific things that make them worse or make them better. And so those are the sorts of things that I looked for when I did her examination, and I did not hear any current murmurs, and I made her do the sorts of maneuvers that could exacerbate or worsen a murmur or bring out a murmur, and I never heard a murmur on anything that she did. Okay. And so I'm really reassured by that physical exam. I can assure you that as her doctor, I'm certainly concerned about her health, and I have a really pretty low threshold for sending people to see specialists, and so if I were at all worried, then I would send her to a cardiologist.
So just to make sure that you guys hear this, so this standardized parent, after the resident had already explained everything, she was still worried, and she basically asked, well, wouldn't it be a good idea? Now I have to say that this standardized mother was really nice because she shared her underlying concern without the resident having to dig deep into it. So she did say, I'm worried because there is someone who died on the field, somebody that she knows is going through cardiac evaluation, so what's the harm of just going ahead and seeing the cardiologist? And this is where it becomes tricky. I think I'm the first one to admit it's much easier for me to do an echocardiogram on a child that I think is normal than to spend time counseling the family that the child is actually normal. So, but the reality of thing is that testing is not the therapy for parental anxiety. What we have known from the SCANS exercise is that the higher the number of testing that one do, the higher the anxiety level of the parent, father, or mother. We don't know which is driving which. Is it the parental anxiety that's demanding further testing, or is it the more testing that the cardiologist is doing that lead to more anxiety, or is it versa? Now, that being said, when you are dealing with such patients, my advice is to go back to the communication skills that you learned as a medical student. You go after that most concerning factor. Larry Greenberg makes it his habit to start with the most concerning factor from the get-go. I myself do it after I'm done with the examination, when I start thinking about the differential diagnosis and the possibilities. That's when I go after the concern. And you can go after the concern by asking, what's the most concerning thing for you today? Or, this is a lot to deal with. How did this impact you and your family? You can go after the effect by asking, how does this make you feel? Or, you seem to be worried or you seem to be anxious. Can you tell me why? And often, you can get to the underlying drive for the referral and counsel the families appropriately. I am an 80-year-old cardiologist, so I don't have tons of experience, but one time the most concerning thing for the family was absolutely not sudden death or something serious happening with the child. It was the mold in the school, MOLD. This is a family who were convinced that the mold in the school is the cause of headache, vomiting, and syncope in her child. And she and many other parents wanted a letter to state that it is unsafe for them to go back to school. And despite all the skills that I have learned teaching residents and as well as the skills that I learned early on, I failed to realize that the underlying concern was actually something absolutely nothing to do with sudden death or the heart. It was more of the mold. So, you really don't know what the underlying concern is going to be unless you ask for it. And you're not going to reassure those families with doing more testing without going after the underlying concern. This particular resident, I thought, did a very good job with counseling the family. The one correction that I want to make is it's not just hypertrophic cardiomyopathy that we want to rule out. We want to rule out all structural heart disease, and she appropriately stated arrhythmia, which is a very good thing. I like what she ended her counseling with. She said, I have a very low threshold for referring patients, so if there was anything that made me concerned as a pediatrician, I would have referred this patient to the cardiologist as well. Now, one of the things that we do is we do Plan B with the family. Plan B means, okay, so if this fails, when should you be worried as a pediatrician? And let's hear this encounter.
All of the information that you've given and her perfectly normal exam makes me comfortable not sending her to a cardiologist at this time.
Okay.
If things were to change, if you were to come and start to tell me a story that were different, if she passed out in the middle of exercise, that's for sure something that I want you to come tell me about.
Okay.
Particularly, that would be like the biggest thing I think at this point that would change, that would make me feel like I needed to send her to a cardiologist.
Okay.
And then I'm also going to give you some just information you can give her, things like staying hydrated, keeping her salt content up a little bit, and then I'd like to see you and her back again in a month, just to see if she's been having any of these episodes again. Okay, I'm going to give you a journal that you can give to her, basically to track some of her symptoms, and it'll say, it'll just kind of be a grid that says the date, if she passed out, if she passed out, then she definitely going out for that day, but even if she feels close to passing out or just feels a little bit dizzy, I'd like her to fill out an entry. And then any associated things that happen with it. Did she get blurry vision? Did she feel like she was going to throw up? And then how much water she drank? And then the color of her urine.
So this resident just went through when should you be worried as a pediatrician and what things will make you send the patient to cardiology. So exercise-induced syncope is not just the child fainted during gym class. I will encourage you to get deep into the information and try to understand what happened exactly. The best person that you want to talk to is the teacher who saw the event or the student who actually was the witness of the event. That might save you a lot of time. As a general cardiologist, I find myself doing that often and making the first phone call to the school nurse or to the school teacher and saving a lot of time and resources doing investigations, etc. Because the implications of true exercise-induced syncope implies that we will be doing tons of testing. And the exercise-induced syncope means, as the resident just stated, during activity, you are running and you faint, or you're about to score the winning goal and you faint. This is what I would be worried about. I will also be worried if immediately after you were done running the track, immediately within 5 minutes you faint. That is the recovery phase, and we still will be worried about it. On the other hand, if 45 minutes later you had your shower, hot shower already, and now you are awaiting your award, and then you get dizzy and faint, that's most likely going to be vasovagal syncope. The residents, I think they tried their best to educate the families, and one of the tools that they have been using is to say, okay, here's a log of things that I want you to monitor over the coming 2 weeks, 3 weeks, etc. One of the things that you as a pediatrician could do is have a fixed follow-up appointment for the family, and just to make sure that things are going the way that they should be, as opposed to immediately sending them to the cardiologist. We use another case to, stimulate the resident as well. And this one, the patient has a true cardiac disease. There is a significant history. This patient fainted because of a loud buzzer. If there is any electrophysiologist on the call, they will tell you that this can suggest long QT syndrome. The other concerning thing is the older brother drowned at 21 years of age with really no much data provided, so that's also concerning. This is a patient who will need referral, and the way that we stimulate the resident is by putting multiple obstructions for that referral to happen. For example, single mother who doesn't have anyone else to take the child and had maxed out on all of her days off because of the sibling who has asthma. Things like that, just to make the residents get stimulated and have them counsel those patients as well. Many of the encounters that I have witnessed have like common themes. So the ones that the residents got stuck with or had hard time with were when the standardized mother would say, well, how can you guarantee that my son will not be the next one to drop him in the field? And my answer to that is very simple. My answer to that is, I cannot guarantee that. The cardiologist cannot guarantee that. No one on God's earth can guarantee that. This is something only God knows. So there is absolutely no way for us cardiologists to prevent sudden death from everyone. As a matter of fact, I keep quoting that soccer players, most common cause of sudden death in them was myocarditis, and despite having a pre-sport evaluation months in advance, they still had myocarditis and died from it. So there is absolutely no way for us to prevent sudden death from happening, but we use the skills to identify those at high risk and refer them to cardiology. How can you be 100% sure? Again, the same phenomena. Now, the goal of the scams was to identify cardiac disease explaining chest pain. So I didn't really elaborate on the incidental findings that we found, but there were some incidental findings. About 140 of them had a minor patent foramen ovale or a small arterial septal defect or a mild pulmonary valve stenosis. None of these are life-threatening. None of them required immediate intervention, and I would suggest even further that none of them was dangerous not to be identified by the cardiologist at that time. Our next plan is to develop the entire curriculum online and to take this to the home of the pediatrician. So if you are on this phone call, I am hoping that I have excited you enough to participate in a future quality improvement initiative. The goals are to reduce practice variation and reduce unnecessary testing and improve care. I'll be more than happy to take any questions. And thank you. Does anyone have any questions? If not, I do have multiple choice questions that we can go through them, 5 of them. But let's see if anyone has any questions. I don't really see any questions coming through. Is there any problems with the audio? There should be a chat box open. I just typed. If you guys have any questions, feel free to ask. Okay, while we're getting some questions, let's go ahead and do this question here. This is an MCQ. We have a 15-year-old football player who presents for an evaluation of a Syncope episode that occurred during a game in early September. His father states that his son amazed 200 yards running with 3 touchdowns in the first half of the game. 20 minutes into halftime, while standing on the sideline, he looked pale, then fainted for 10 seconds. He was awake by the time that his father reached him. The boy did remember feeling dizzy, blurring of vision before fainting. On examination, his heart rate was 80, blood pressure was 110/70, and he had a normal first and second heart sound with a 2 out of 6 early systolic murmur while lying supine that decreased to 1 out of 6 with sitting up. He's 70 inches tall and weighs 180 pounds, and he began shaving. The most appropriate next step is increase daily fluid intake, refer to cardiology, refer to neurology, refer to the emergency department, and prescribe oral tablets prior to the game. It will be really nice if you guys type in your responses just so that we see where we are. So this patient finished the game, 20 minutes into the halftime, had the complaints. He felt the blurring of vision or dizzy, so he had the prodrome. And yes, he did have a heart murmur, but it's the innocent, benign heart murmur that decreased with sitting up. So this is a patient who needs reassurance, increases the fluid intake. There is no need to send to cardiology, neurology, or emergency department. And while some of my colleagues use salt tablets as first-line therapy, I use it as second-line therapy, but if you use it, you don't use it just as a PRN therapy. You use it as maintenance and prescribe it on a daily basis. So our second question is an 8-year-old girl who had retrosternal chest pain for a week. Her general examination is normal. Which of the following characteristics will make you worry about a cardiac disease? Sharp, stabbing nature of the chest pain, the pain that occurs only at rest, only with inspiration, only with exercise, or associated with point tenderness. So I will be worried about number D, the chest pain that occurs only with exercise. All the others, they can be related to musculoskeletal or pleuritis type of chest pain. And I'm providing you here with the red flags criteria for referral. We're evaluating a 15-year-old who presented with chest pain. The pain was not radiating and not associated with sports. Family history was reassuring. There was absolutely no concerning elements, no underlying cardiac disease in the family, no one died at a young age, unexplained sudden death or drowning. The examination was normal apart from a reproducible pain at the left lower sternal border. After explaining the benign nature of the chest pain, the mother became angry, crossed her arms, and mandating a referral to cardiology. So the best next step is, now one thing to mention here is that in our SCAMP cohort, we found that if you had a reproducible pain on palpation and did not have exertional chest pain, that you had a 0 chance of having a cardiac disease explaining chest pain. So the most appropriate thing to do, refer to cardiology, refer to emergency department, ask the family to see another pediatrician, or obtain an EKG, and finally determine the concerning element. So in this particular case, it's very obvious that we need to go after the concerning element. What we know about children with non-cardiac chest pain is that their parents have somatization, that the children themselves have underlying anxiety, depression, panic attacks, and that we ought to go after the concerning element. I did not really share with you data on this, but in the SCAMS cohort, we actually saw that EKG does not help in identifying cardiac disease for those with benign clinical elements. So if you had a normal history, past medical history, family history, and examination, EKG was not helpful. As a matter of fact, the 125 children who had a normal EKG did not have cardiac disease explaining their chest pain. So I would argue that such patients might not need an EKG, yet 90% of them got one when they came and saw the cardiologist. You're evaluating a 16-year-old boy with chest pain. The pain occurred while the child was sitting. You decided not to refer the patient to cardiology. One of your medical students rotating with you asked about cardiology referral criteria for patients presenting with chest pain. In answering the medical student, which of the following is true? A, the majority of patients referred to cardiology with chief complaint of chest pain have an underlying heart disease. B, about 50% of children with non-cardiac chest pain have associated panic disorder. C, no known red flag criteria has shown high sensitivity in identifying cardiac disease explaining chest pain. D, all patients presenting with chest pain need to see cardiology. Finally, all patients presenting with chest pain need to be exercise restricted. Okay, thank you. I finally got a response. By the way, this type of board question is like my favorite. You think that you know the diagnosis, but then they open it up with a medical student asking a question, and then all gates open on you. Okay, so the correct answer for this one is actually B. As you guys saw, 0.25% of children referred to cardiology with a chief complaint of chest pain had an underlying heart disease. So A is absolutely wrong. I hope I convinced you that D and E are not correct. By the way, if you had enough clinical elements to suggest cardiology referral, please exercise restrict those patients until they get evaluated by cardiology. And no-known red flag criteria has shown to be high sensitive and identify cardiac disease explaining chest pain. This is the exercise that we did with the medical red flag that identified the true cardiac disease with 100% sensitivity. So I would say that C is wrong, and the only correct answer is B. There were multiple reports looking at children presenting to cardiology with chest pain. Some of them were conducted at psychiatry offices. They took those kids and did a psychiatric assessment and found 25 to 47% of them to have underlying panic disorder. Of interest, the children and the parents who present to cardiology with non-cardiac chest pain have more psychiatric issues than children and parents who present to cardiology with innocent heart murmur for some reason. So I'm not sure why question number 5 was missed. Well, it's about 12:58. So if you guys have any questions now or later, feel free to contact me. I'm more than happy to answer your questions. I hope that I have empowered you today to send me less patients. If Charlie is listening, sorry Charlie, but I'm empowering pediatricians to take care of their patients, which I think is the goal of this presentation. If you have any questions, feel free to contact me. I'm more than happy to answer any of your questions today, tomorrow, and the day after. I'm hoping to work with the team at Children's in developing QI projects across the community with regard to chest pain, syncope, and other subspecialty referral issues. This is my email, my phone number. I'm more than happy to answer any of your questions, and thank you guys.